and a pleasure, and I think for all of you can, I think, appreciate this. It's kind of a unique opportunity tonight because the SIR is in town. People of Chicago get a chance to really question. We're going to have time for you to ask questions. Basically, 90% of the people, the intelligence in the world on this. We've got all the people we can put together here. So this is kind of like, you know, the murderer's row of the New York Yankees here. You got them all here. So you can ask questions as you want. I'm going to introduce them. First, immediately on my right is Bulent Arslan. Bulent and I were close colleagues at the University of Virginia. Now Bulent is Associate Professor of Radiology at University of South Florida, and he works at the Moffitt Cancer Center. He's had a lot of experience in this, and actually with the group of CCSVI Alliance had a wonderful program similar to this just about a month ago down in Tampa, which was a huge success, and we had a rock and roll kind of outing around a lake down there. It was a lot of fun, and we had people in the front row can attest to that. So Bulent's here. Second, we have Mark Hickey. You all know Mark. He's from Wayne State. He's director of MRI there. Has done a lot of the seminal work, and Mark's actually going to have a few slides to show you later, so we'll kind of work that in. You met Gary, who's professor and chairman of radiology at Albany and director of interventional radiology. You may not know Dr. Noronha, and we're really pleased you could come. We put him right in the center. So he's works at the University of Chicago. He's an MS neurologist, and so he's going to keep us on the straight and narrow and keep us on task here. And it's a pleasure to have you here. Steve Pascal is vice chair of radiology, director of interventional radiology at the University of Maryland. He's the new editor of JVIR, which is the journal for all those who are interventional radiologists. And congratulations, Steve. And he's also treated many patients. Suzie McCann from Vancouver. So we have a Canadian perspective here, and that, as you well know, Canada's been leading the way in many of these discussions, and certainly I think is the cradle of, I guess we would say, debate on this. And Lindsay certainly has been involved in this for a long time. Great to have Lindsay. Sal, you know Sal Kahn, who's a professor and chairman in New York City, downstate, and has obviously been involved in this for a while and is devoted now, very dedicated his career and his life to CCSVI, and has held events in New York City, and has also been very active throughout internationally in this, and is active in the New Society, International Society of Neurovascular Diseases. Don Ponic, you heard about Don, who treated Christina, our patient. Don is founder in San Diego of the San Diego Cardiac and Vascular Institute, and is director of interventional radiology at Tri-City Medical Center. He's been involved in association with the Hubbard Institute and is going to share with us. He's got some slides. We picked a couple guys to show you slides tonight to sort of break it up, the discussion, but also because they have some unique things that are a little, I think you'll be pleased to see, and we'll put a different perspective. So the plan is that just a little after 7:30, we're going to go to 8:30, and I'm going to start by asking some questions, and we'll take maybe 20 minutes. So then we're going to open it up to you guys. And the name of the game is questions, as Gary said, and we may not have answers for all your questions, so we're all prepared to say, I don't know, or we'll have to find out. But I think, as Gary said, research is key, and that's one thing about, as he said, we all live sort of we're just at the sort of beginning, the sort of toddler phase of CCSVI. Likewise, the CCSVI Alliance, I know that one of their aims and goals eventually would be to be in a position to support some of this research. So that's one reason why you should support them, so they can obviously make wise decisions on your behalf to support research that may be ongoing in North America. So let's go ahead and get started. Now, I kind of want to cover with our panel a few topics. We have some questions that come in from the internet, so I'm going to use those from people who posed them through the Alliance. I had some questions myself. I'm going to start with sort of about the area of diagnosis. Gary handled a lot of that, and sort of these associations. I mean, do normals have CCSVI? Do other neurological diseases have CCSVI? That sort of stuff. And then we'll spend a little time on the actual procedure itself, and then we'll finish up with some questions on basically follow-up what you should do after you've been treated, what happens if you get symptoms come back, what does that mean, how do we monitor, things like that. And I'll start the ball rolling by asking one of our panelists the question, but if any of the other panelists feel they've got something to contribute on this, you should speak up, okay, rather than go through the line. So the first question actually comes from, I wanted to sort of get it out there because we really didn't cover in Gary's talk about what percentage of MS patients have CCSVI and what percentage of non-MS, so-called healthy subjects, may have CCSVI. Sal, do you want to take that? Anyone can take it, but what?
Thank you. I think that's a very difficult question because the literature is confusing. It goes from 0 to 100%. So it's somewhere between 0 and 100%. I think that it really depends on how you look for it and how subtly the findings are that you will accept as being abnormal will help you determine what the maximum number of, and the maximum number is probably closer to 100 than 0. If you look at the trials that have a high percentage of patients who have, or don't have MS, who have CCSVI diagnosed, those studies are a bit flawed. They really include in the healthy controls family members who may have a genetic predisposition to the venous malformation. So it becomes one of those questions where we don't have the pure answer. And my own personal experiences, which is really what I can rely on the most, is that almost every patient that I've studied I've found abnormalities of the veins. Whether all of those abnormalities of the veins are instrumental in causing symptoms is another question that I can't answer yet. But I think that this is a very common problem among patients with MS, and the percentage is not really important. If it's 80%, there's no way to discriminate a patient with MS who might have it from one who doesn't have it. So testing becomes the only way to really evaluate an individual. And percentages are interesting, but I don't think they're that important. The marker is multiple sclerosis.
Fair enough. Lindsay, can you, I know this is a tough question and you may not be able to answer it, but do you think CCSVI is a consequence of the MS, or do you think it's somehow, are you born with it? Do you acquire it? Based on what we think of the anatomy now, I mean, this is a blue sky, we won't hold you to this. But.
I honestly have no idea, and we're doing a trial right now where we're blinded, so patients are coming to see us, and we're doing venography, catheter venography on these patients, as well as ultrasound and MR. And we have normal people, we have relations, we have twins who don't have MS, and then we have patients with MS. And I go in, I have no idea. The patients are covered up, I don't know what they have. And so all I can tell you is after a fair bit of time of looking at this, I am still left utterly confused about this, and open-minded, but I really don't know which way as yet.
So, Dr. Narana, let me ask you a question now, because I got 3 or 4 questions from the internet that are along the same line, and I also wonder, these questions go something like this. How can doctors who are currently not treating CCSVI be persuaded to be engaged with this? Or rather, how can we engage neurologists and other physicians in further investigation?
Those are good questions, sir. Could I add some numbers to the previous question?
Sure.
Yeah, okay. So actually, Bob Zavadanov had a paper and looked at this. And the numbers are the following. 56% of his MS patients had the abnormality. Also, 23% of normal controls, and 42% of other neurological diseases. So the numbers are distributed across these 3 groups, and while there is certainly a good a good number of people with MS who have it, but they're also the controls and the other neurological diseases that have it. So it becomes difficult to separate this out. All right. So there's data, and that's the data. So now
I think you're correct with that one study. The problem is that there's not a reproducible legal tender between studies. An MRB, as Mark will tell you, is not an MRB, is not an MRB. Likewise, performing this rather nuanced study with ultrasound is going to be, at this point in time, extremely variable from site to site. Why don't, Zeke, you want to? Did you want to say
I want to emphasize the things that we're saying, which is a couple of things. We're measuring these things differently from paper to paper, and the hallmark of clinical science, and the reason why you hear study after study over the same thing, is reproducibility. You know, everybody is optimistic with the first study in something because you've discovered something new. And there's always a bias to finding out that this is the best thing. We look for the best thing, whatever we're treating, and then it's only through repetition that we find out what is and what isn't. So we have a paper that says that it may well be 50% or 25% or otherwise. We have other studies that say it may be less or it may be 80%, but as Dr. Sclafani said, it really doesn't matter, because we don't have to say that if you have MS, that everybody has to have vein narrowings, and if you have vein narrowings, that you have to be a responder. What we need to just say is, how do we find out if you do, and what's the connection between A and B, which is we can find it, you can have it, and who responds. And whether that's an 80% or a 60% or a 50%, let time figure that out.
I agree with you 100%. So back to Dr. Naran on my question,
Absolutely.
which is, how do we reach out, engage our colleagues in neurology to collaborate in a meaningful way to try and answer some of these questions? Because quite frankly, I go to more meetings, and I oftentimes have a neurologist say, this cannot be done without neurologic involvement. So, and everyone says, you're right, but trying to actually get that neurologic involvement has been problematic in some sense. So give us some insight of how we could, your colleagues in neurology, how we can actually, in a non-threatening way that doesn't diminish the immune theories, really get them involved.
So the best way to answer this question is to conduct a clinical trial. And we have a lot of experience in conducting clinical trials. I actually studied the first drug that was ever approved before it reached the approval stage, and then put it to the test in a clinical trial. So the clinical trial is the way to go. And this is a clinical trial that's not so difficult to design. It can be done. And
So do you think, again, I don't want to get into too much detail here, but obviously the MS Society decided we're not ready for clinical trials. We're just going to have to study with the grants they've given out, the associations between this and MS. Do you think the neurology community now is ready to entertain a randomized, well-designed clinical trial on this?
so to start, it has to be at a place that has done clinical trials before, okay, that knows how to do them. Data that's good, data that tells us about MS before they go into a clinical trial. So large centers that do clinical trials and have many patients with MS would be...
So you think that these centers, they are now, your neurology colleagues would be willing to say, okay, we'll design this together and move forward, even though we don't understand this association, as Zeev and Sal said.
It's one thing to say that that's the best way to get the answer, but our centers willing to commit their resources to doing this. So that's the second part.
Okay,
So in order to do that, the centers that will do the study need to get data that's convincing them that there is something that should be investigated in the clinical trial. So there's more data needed.
Okay, well now you kind of hedged me in a way I'm not really sure what's...
Well, I mean, if I could look at it another way, the natural progression of clinical research is there's feasibility. If you're a surgeon and you want to do an operation, you don't start your study on day one. You first figure out if you can accomplish the operation, if you can do it safely, if you can have a technique that makes sense. And then you do a clinical trial in which you look in retrospect, what did I do? What did I find? And then maybe you look forward. And at some point, the question is it time or is it appropriate to say randomization? So maybe a way to ask the question of the panel is, are we ready for the randomized trial, or do we need to be in the saddle looking at diagnostic studies, and can we do a randomized trial or many? What would you say is a neurologic perspective on it?
Well, to begin with, if you are designing a clinical trial, you should have a hypothesis. So let me turn it back to you. What is the hypothesis here in terms of the abnormality in MS?
I think we're going to get as broad a series of answers as we have people here. Maybe sort of the quick answers from everybody. Lindsay, you want to?
I think there's only one question that needs to be answered right off the bat to put this to bed. Does intervening in the jugular veins in patients with MS alter the outcome of those patients in a measurable way?
Yes.
All those other questions about, the specifics of the pathophysiology, with respect, there's been lots of trials done where we really didn't understand the pathophysiology, and in fact, learned completely different pathophysiologies of disease long after we started treating them. So I think that's not a fair thing. We need to answer this question so, A, we can stop people from having false hope if there really isn't anything here, or B, actually appropriately evaluating these things and, and then moving on to how do you treat it.
Mark, did you? Oh, go ahead, Sal.
Well,
Mark? Sal.
let Mark go first.
Thank you. I think, Steve, you opened up an important point here, and that is, before you can do a randomized trial or a double-blinded trial for that matter, you have to have an observational study. And the problem here is that I see we've now reviewed more than 1,000 cases. There are many, many variables here. You could not have designed this study correctly the day after Zamboni published his paper. Now that there have been on the order of 10,000 or more cases that have been studied, we have enough understanding of this. This is true from the imaging point of view, it's true from the patient recovery point of view, and it's even true from the interventional radiologist point of view, where there are still many of you who perform these treatments slightly differently. And in order to make this study a realistic study, you're going to have to choose some common denominator or baseline between all of these methods that are being used today, and then go forward with that. They may not necessarily be the best, but they have a chance to work. The difficulty with all the other papers and studies that have been done so far is they're all done differently. So they really can't be properly assessed from a scientific point of view. And they use far too small numbers. In order to do this job properly, you can't do on the order of 50 or even 100, in my opinion. If you have 50 variables and you need 10 to 20 per variable, you're going to need on the order of 1,000 patients to do this job properly. So there are a lot of things like this that need to be considered.
So let me ask you, is there good enough data from the sham studies that will help us design a trial? The ones who receive the sham operation?
Well, at least at this point right now, we have, sham study. We have a sham study going on right now. In Albany, New York, we're running a randomized, double-blinded study. It's early. Sure. So, as Dr. Haskell was alluding to, there are different levels of evidence that we look at, and what a prospective study means is that we're going to enroll patients in a study and follow them moving forward. So that's a prospective study. It's felt to be a little bit more powerful and a little bit more meaningful than studies where we just do a bunch of cases and look backwards at what was done. And so most people feel that a prospective study is really the way to go. When we randomize patients, it means that we randomly assign them to a group, meaning one group receives one course of treatment or action and the other group receives another. And when it's blinded, it means it's blinded to one or more parties involved with the study. Now, when you're doing a study like this, evaluating this type of procedure, there's three parties that need to be involved. There's the patient, there's the neurologist, and there's the interventionalist performing the procedure. Now, obviously, there's really no way the interventionalist can be blinded. So when we, at least when I refer to a double-blinded study, it means the patient is blinded and the neurologist is blinded, meaning that the patient can report what they're feeling objectively, and the neurologist evaluating can report what they're seeing objectively without any bias as to what they think they had done. Now, we're involved in that, and admittedly, we got started early on it. We were very fortunate that we work in a medical center where we have a supportive neurology team, a supportive institution to do that, so we're fortunate, and everybody involved thought that this would be the best way to go about answering some of the questions that we had about this. So we're starting that, but it's possible to agree with everybody and maybe seeming like we disagree. We need a lot of research here. We need to do these retrospective studies, these observational studies, these single center studies to answer as many questions as we can. But one thing I am definitely of the opinion is that we can do this simultaneously, is that we can look backwards and forwards at the same time and try and get some information. I think that if we all gave our opinion as to what the perfect study was, we would give you 7 or 8 different answers as to what the perfect study was, and I would predict that if we waited 2 years to answer that question, we would still give you 7 or 8 different answers as to what the perfect study was. So I believe that there may never be the one perfect study, but every bit of information we produce is just maybe solving a little bit of that puzzle one step at a time.
I think it's a step-by-step process, and as you say, each step may illuminate the next step we take towards getting more information. Let me ask you a question.
Could I follow up?
Well, I'd like to.
On his study. Yeah.
Okay.
So it's great that you're doing study. That's excellent. So I was going to say, are you going to incorporate some neurological measures into the study? So I'll mention what measures would be useful in case you're going to study them. Okay, so we need to do look at mobility. So we need to do what's called an EDSS, and that's a scale, 10-point scale, and we do this in all clinical trials, and we have a number. So we need to do that before the procedure and follow it after the procedure. All right. The second thing, we know that cognitive impairment does occur in MS. It's under the surface. It needs to be measured, and there are cognitive tests that can be easily done. There's something called the PACE-SAT, cerebral auditory testing, and there are other cognitive measures that can be easily applied. So you can show that besides the attack rate, you can show an effect on ambulation, the EDSS, and cognitive function. That would be more.
I think that's critical, Dr. Naran, and I think we all appreciate all the multiplicity of metrics that we'll need to really prove to make neurologists take it seriously.
Absolutely, and in 10 seconds what I can tell you is that our neurologists helped design the outcome measures for this study, and they are inclusive of the things that you mentioned, plus many others.
So let's we're running close to the end of our time for my questions. We're going to get to the audience. I want Mark and Don to have a chance, but let me ask you a question. In your experience, what symptoms respond to PTA? What do you expect to reverse, and what doesn't tend to improve? Now, obviously, you're going to have to generalize, because we're all going to have onesies, twosies, but is there a way you can sort of inform the audience about what you tend to look for and what you sort of advise patients? And then if anyone else wants to comment, go ahead.
I think one of the most common things that I see improve is bladder symptoms in a lot of patients. It's amazingly improving. And ambulation, if they're not completely wheelchair bound, I see them they're getting improvements in their level of ambulation. But if they're completely wheelchair bound, that's kind of hard to overcome it at that point. And I had 2 patients whose vision was completely gone, 20/200, who actually by ophthalmology examination went to 20/30, which they started seeing. And neurologic symptoms improve, their tingling, etc., pain. Sometimes several patients, I'm sure all other guys here examined that too, come into the room with a purple cold foot and then come out of the procedure, it's pink and warm. I don't know how to explain it, but it's an immediate change I see in several patients. And just a broad range of symptoms. Some of the cognitive symptoms do not change very much. I have not seen that, and it's actually very difficult for me to observe as well. But what I try to do is, in my practice, I strongly encourage all my patients to continue to see their neurologist. Coming to your initial question, how can we get this kind of accepted by everybody? We see the results, promising results, patients are telling us and then happening, but they don't see it. If they're refusing to see the patients, you know, they're not going to see, they're not going to believe it ever. If they saw the patients, they may change their minds. And my first patient, her neurologist didn't want to refer her for the procedure. She found another neurologist, and she eventually ended up with me. And I went back to the neurologist who was following her initially, and she underwent all those tests. She had a dramatic improvement in her ambulation by his testing, etc. Now that neurologist is referring patients to me, aside from 2 other neurologists in
And I
Tampa.
can sort of attest to this, that there's a very nice working relationship in Tampa between the neurologist that's been established and interventionists, and sort of a true collaborative effort. So, okay.
And one more thing, and the trial is obviously, no one can argue with that, is the right way to go. But I think surgeons have done carotid endarterectomies for patients who have blockages in their arteries going to the brain. The belief was that they may be on a high risk to have a stroke and have problems. So they were being treated by surgeons for about 50 years. And neurologists never believed that until 1980s, when there was a trial, large, over 2,000 patient randomized, which proved the benefit of the procedure. Only after then, every patient with that blockage, if they had symptoms, started to get treated on a regular basis. So this is not an easy process, and we're just at the very beginning of it. Everyone needs to kind of put effort, contribute, so we can come somewhere.
Don, can you come up and, I'm going to ask Don Ponic to come up and show some of the, one outcome measure that they use in their work in association with Hubbard that many of you may not be aware of, but I think is kind of interesting. So while Don is sort of teeing up here, Sal, could you just quickly, in your estimation, when you're on the table, what percentage of lesions, now we're not talking about patients, just lesions respond to PTA alone when you're into procedure?
What's PTA?
That's angioplasty, balloon angioplasty. Well, that's a very good question. It depends on when I started.
We'll say now, in your...
Right now?
Yeah.
The vast majority will open up. Using IVUS, I've been able to show that the vein is opened up. The vein the obstruction is usually the valve leaflets are either fused or scarred together or malformed in that way. And I think the IVUS has helped me identify more abnormalities. IVUS is an ultrasound device that's put inside the vein, and it gives very precise analysis of the interior of the vein. And I'd say most of the stenoses respond. It requires aggressive pressures sometimes to get them open, but they usually open. The challenge is not getting the vein open. It's not injuring the rest of the vein. It's really my challenge.
And we're going to talk about that in just a second. And I'm glad you said that. But you also heard what he said. He said, he said, you mean now or when I first started? When people first started with this, and I think many people now, we were impressed at the first annual ISNVD meeting in Bologna. Some people have said it took them 100 cases before they really felt equipped to judge, not just blow up the balloon, to really understand how, to get sort of in a groove, if you will, and that's understandable with anything new.
Can I emphasize a point to what you're saying? Because we've talked about the need for research, which is going to move this forward, and in parallel, people are going to have the desire and interest in finding out whether this is meaningful for them in parallel to research, whether it's available or not. And you're also hearing about a serious learning curve, which means physicians learning to do this, and even sometimes the more we do, the less we know. So perhaps at some point this evening you talk about the kinds of questions that you want to ask if you're searching this out for yourself outside of the setting of a research trial, because there are going to be a lot of variabilities in ability to do this or endpoints or how you do it, and you want to be informed consumers in an area that is gray where there are more questions than not.
Good point. Okay, Don, why don't you share with us?
Thanks, and thank you for having me, and Sharon, thank you for putting this together. I'm Don Ponic, I'm an interventional radiologist, and as you heard earlier, I got involved in diagnosis and treatment of CCSVI about a year ago. And at that point, we were trying to figure out where, I'm in a private practice, it's a large interventional practice, but still private practice, where does that fit in? And we felt strongly that our role was to try and establish where we should be in the spectrum of research, and we really felt that a single-armed registry or single-armed trial with IRB approval was the appropriate place, because this would then standardize what it was we were doing, how we were looking at things. And as we mentioned earlier, research starts with an observation, some sort of theory, some demonstration of a connection between the theory and something you can do, a procedure that you show to be safe and then hopefully effective, and then you test it against other known therapies in some sort of trial. Those more advanced trials are certainly, in our estimation, university. We thought, the registry trials are kind of where we belong, and so we're trying to do that. We've had a few interesting things as far as patients who were so-called normal, who had narrowings. We found the same thing. About 22% of our patients by venography who did not have MS actually did have some sort of narrowing. The positivity, though, depended on how you look. MR venography was about positive in about 60% of patients, but when you looked at flow quantification, which was more sensitive, it was in the high 80%. And so it really did depend on how you looked. The first thing we wanted to, for me anyway, was to find out, was there some sort of real physiologic underpinning for this? And that's where Dr. Mark Hickey and the functional MRI study came in. And I've cut about 30 slides down here to about 5. This bold fMRI is just a fancy name for, it's a way of looking at blood flow in the brain as a function of some sort of stimulation or activation. And it's a kind of a highfalutin fMRI test that we need physicists like Dr. Hickey to help us with. I read MRI and that sort of thing, but this is really more as much physics and physiology. We did study 20 patients with multiple sclerosis against 20 normal controls. We had them do cognitive tasks that created some sort of maximal cortical activation, and then we retested the patients with MS after treatment for CCSVI. And what we found was that the MS patients demonstrated reduced activations in these certain areas, and default so-called task negative network showed pronounced differences in MS patients to normal controls. That reversed after the treatment. It was at a highly significant level. Those fMRI characteristics changed after the intervention. And so this, to me, was very reassuring, because it meant that there was some sort of real physical, this is sort of, in my mind, placebo immune. You can't think up a way of changing the flow to your medial temporal cortex. So it's just something that your body's doing, and so that was kind of helpful for me. The second thing was just to look at the clinical outcomes, and we're using a tool called the MSIS-29. Some of you may know it. It's a way of following our patients. We studied our first 225 patients along these lines, and again, this is highly compressed. But we did find at a 0.01 statistical significance at 1 month and 6 months response in both physical and mental health response scales in the patients who were treated. We also mimicked the same safety evidence or safety results that you'd heard from 2 other trials. Our first 250 patients, it turns out this is a very safe procedure overall. There are still problems. It is an invasive procedure, but safe. And that's what I had.
Thanks very much, Mark. While Mark's he's got a couple slides that we want to share with you, but let me ask anyone, but maybe we start with Gary. When patients come back after initially responding with some symptom improvement, and they come back at some variable time and they think their symptoms have come back, we often know that indeed the venographic appearance shows that there's been some re-narrowing. What do you think that re-narrowing is, and why, and what do we do about it?
Well, I think first, a couple of questions. You threw a lot in there. The first is the variable amount of time. And it's our feeling that there's a lot of people who come and have this treatment and feel better, they feel great for a week or two, and then they say, my symptoms are really starting to come back. The first thing is that we encourage our patients to wait at least 3 months, because we have definitely seen some patients who have a bit of a delayed response to this, and it makes sense to give it some time. When we see patients who inquire about them, when we hear from patients, we like to get a sense of what the extent of their response was. And it's difficult for us to distinguish between patients who maybe never had a response at all and want to be retreated, patients who had just a short duration good response and want to be retreated, and then patients who've had what we all would consider to be an amazing response that then goes back to baseline and they want to be retreated. Right now, we've been admittedly fairly conservative in our approach to retreatment in that we want to see patients who really had a great response that lasted, a significant amount of time and then came back. And when we see these patients, we oftentimes see that their veins have re-narrowed. And at least for right now, I'm not comfortable telling you that I completely know, but I think that it's different than dealing with a patient who hasn't been treated yet. Because when we're dealing with someone who's been treated and they have a re-narrowing or a re-stenosis, it could just be that the valve didn't respond in the first place and just kind of flopped back to where it was originally. But it can also be due to an inflammatory response that we created with the angioplasty. And so, in fact, those may be two completely different issues that we're trying to treat. And until we get a real understanding of what is responsible for restenosis, I'm not quite sure that we're going to know the best way to approach these patients, which is why, as admittedly aggressive as we've been from a primary treatment perspective, we've been that conservative with retreating patients, because I think there are a lot of questions that still need to be answered about that.
I think that's...
Could I ask him a quick question?
No, I think we can't.
No, when you hear from a neurologist, he
We
doesn't
gotta
want
move
to
on, yeah. I think Mark is going to, and maybe during the questions from the audience we'll ask some more, but I want to get Mark's got a short presentation for us, and then we're going to turn it over to the audience to ask questions.
So I think since you saw me adding some extra slides here, I think since we have some neurologists here and people who are doing taking care of MS patients on a regular basis. I'm not a neurologist, I'm a professor of radiology, but I'm actually a physicist, and I'm also a professor of biomedical engineering. So my area of interest is in diagnostic imaging and also the research related to the imaging component. So most of you will have had an MR scan. And one of the reasons to have the MR scan is to help the neurologist diagnose what your situation is. Are you an MS patient or not? And so I would guess it's very important for the neurologist to have this baseline study for you. Because if you're going to be treated and you're worried about changes in perfusion to the brain, changes in flow in the vessels, you want to know a year later or 2 years later, whether your symptoms come back or not, you need a control scan. So I would guess that the neurologist would recommend that. And you can see here on the left you have a patient who does have multiple white matter lesions. And so what happens to these? That should be part of these trials that are taking place. Another thing that we can do is measure the small, deep veins in the brain, and we can do this with exquisite detail with MR as well. And again, we can follow what happens to the changes in local oxygen saturation in tissue. This is a very strong marker. And there was a presentation in Europe by Ivo Petrov showing that there were changes in oxygen saturation in the brain pre and post treatment. That's almost the holy grail. If we could really demonstrate that that's the case post treatment, that's like the fMRI study that Don Ponic showed. So that can be part of the study. And the interesting thing is everything I'm showing you here, it may sound like it's all different information, and it is, but it can all be done in one MR sitting. So this is very important information. As part of the MR scans, we also take a look at the vessels. We can look at the arteries and the veins. In this case, I'm just showing you the veins in just for 2 cases. You can see in the case on the left where the yellow arrow is that there's a very tight narrowing of the left internal jugular vein. This is very similar to an example from angiography from Paula Zamboni's first paper. And on the right-hand side is another example where there's actually what is probably a truncular venous malformation. It's likely to be a congenital effect. There is not even a stump of the jugular in this case. And so actually we see a lot of things that may not be related directly to valves, although valves may be a major problem in many cases. There are a broad variety of changes in the venous system. And the venous system doesn't look the same for 2 people. The arterial systems are very much identical for most people, but not the venous drainage systems. And the MR allows you to really visualize that very well. So I'm sorry the 3D image didn't show. So the nice thing about the MR is it's required in 3 dimensions. The interventional radiologist can review this data in 3 dimensions, just like your kids picking up the glasses and watching 3D data or 3D movies. They can now do this with this type of data as well to help guide them in what they do. So what we really do that's critical that Don mentioned is we take a cross-sectional cut through the neck, and we do this on volunteers and patients, and no, we don't really cut you through the neck, but we can take a picture this way, and we call it a transverse image. And you can see in the image on the left, we can see a lot of vessels. We can see arteries and veins. We have a technique that lets us quantify that blood flow in every artery and vein, at least the major ones, and we can draw the cross-sections for these, and we can do the blood flow measurements. So we can see quite clearly what the blood flow looks like almost every 50 milliseconds. So we can get about 20 points throughout your cardiac cycle. So as your heart is beating, about 20 times during one heartbeat, we can get that information, similar to ultrasound. And in this example here, you see that the blood flow stops for a fair amount of the time, and then it increases here. This is very abnormal. We do not see these in normal cases. So the most exciting thing that I want to show you here is this one slide. The images are great, but now we're at the point that, since we've done many hundreds of these quantifications, we can begin to separate out the MS population into 2 types. One, where we see those clear stenosis, where we see clear abnormalities. And the others where we can't. So all I'm analyzing here is data that has come from the MR component. I don't have the angio data yet to compare with this. And what we find is when we compare this data to our friend Dr. Duff, who's an expert in ultrasound, he finds that about 72%, this blue bar here, about 72% of normal people have most of the venous blood carried out by the internal jugular veins. So 2/3 or more of that blood is carried out by those 2 major veins. And what we find is when we separate the MS population into people who don't have stenosis, we get almost the same answer. We get 70.5% at one site where we did 100 cases, and we get 70% at another site where we did 100 cases. 2 different sites, 2 different magnets, same answers. Now the more interesting part is the graph below this. These are the people who have clear structural abnormalities. And you can see they don't look anything like the normal population. Most of them have the blood flow carried by the internal jugular veins lying between 1/3 to 2/3 of the total venous flow. And so, although there are some people that still fall into this category, many of these people, and especially in category 3, which is the jugular veins only carry 1/3 of the venous blood flow, these people clearly have alternate pathways, such as you may have heard called collaterals, that can carry the blood out successfully, because if you didn't get that blood out of the brain, well, you wouldn't be here today. So we all get it out in one way or the other. So I think we're beginning to get to the point that we can start to quantify this data. And one of the exciting things would be is, do the people who show these stenosis and show these abnormal flows, are they the ones that recover the most? Do they have the best improvement in MSIS-29? We don't know yet, because I'm blinded to this data. But hopefully in the not too distant future, we will get these scores, these MSIS-29 scores, and we will see how that correlates with this type of data. So there's a wonderful opportunity for all the people involved here to follow through with this type of study. And I guess if Mike will give me another 15 seconds, I would like to point out that the International Society for Neurovascular Disease is going to have its 2nd annual meeting very close to your hometown. It's going to be in Orlando. Paula Zamboni is the first president of this, and Mike Dake and I are actually the co-chairman for running this meeting in Orlando, and we hope that we'll get a lot of participation from both the MS societies and the professional societies and the neurologists, who many of whom we will be inviting to talk there. Thank you.
Thanks very much, Mark. Now, I promise I'm going to let you ask questions, but Dr. Haskell's been very generous with time. You don't know, but he's supposed to be leading an investigator meeting at another hotel. He wanted to be here, and he's going to have to go over there to... But I want to ask you a question, and this has to do with trial design. Dr. Narana may have a follow-up question, but in any event, here we go. Since, as opposed to drug studies where the effect of the drug may take a year or so to really be confident that it's having effect or not, when we treat with angioplasty and CCSVI, we tend to see immediate, sometimes even on the table responses. How does this difference in time frame from these two different therapies inform or influence your trial design for the next study we might want?
Boy, it's a complicated question. Let me try to answer it in a couple of ways. First thing, to emphasize what you said, is the standard for drug studies is typically half of you get this, half of you get that, and we're going to see at a year what's different. And the question is that the same and appropriate standard to be using for looking at CCSVI? This isn't a drug. This is a mechanical therapy, and its effect, whatever it is, as Dr. McCann said, we don't understand what it's doing. But what we care about first is it doing something or not? And if the effect of it is early on, and maybe not gradual, then maybe it shouldn't be subject to the same 12-month endpoint that has nothing to do with it. Maybe the drug effect is slow and gradual and continuous. Maybe the balloon angioplasty is like this, and then maybe it fades off. And as we heard, we need to be able to do it again. They shouldn't be judged by the same ruler. So I think in designing a study, we may well want to have half and half, if you will, and a measurement of effect that is actually earlier than 12 months and recognizes that effect is earlier, that it's not a drug, and the rules have to be different.
Fair enough. I think we should let you.
Thank you very much, and bravo.
So, as Pete comes off the stage, I think we're going to open up now the audience to you to question.
I had a question.
Okay?
Okay. So I was going to ask you about the data from sham operations, where you go in but you don't actually relieve the stenosis. And what's the data? Do some people get better from this procedure without, just...
Well, to the best of my knowledge, we can't answer that question because there's not enough sham people. Clearly, I think there's a general appreciation and recognition that the trials that are going to then come forward will have some sort of sham arm, whether it's whatever it is. But we don't, right now, we're not able to answer that or address it. Okay, let's go to the microphone. Pass one down to, thank you. Questions? Carol?
I've been curious about the fact that MS seems to be predominantly found in women. And I'm wondering if, and I heard my neurologist say that that was typical for autoimmune disease, that is typically found in women. But I also thought I heard Dr. Zamboni say that it's the same for venous disease. Is that correct? That it's predominantly women or females that are affected by venous disease?
I'll open that to anyone if they want to take that. Lindsay, go ahead.
I treat patients, one of the things I do is I treat patients with varicose veins in the legs. And that's a great question. Certainly the majority of my patients are women. But what I don't know is most men wouldn't come in saying, I can't wear my shorts during the summer. You know? So I'm not trying to minimize your question. I honestly don't know if it's just a selection thing or if that's true.
Well, I will tell you, now this is kind of, because I don't know if anyone else has anything, I'll just throw up our experience in animal models that we've done, that when we do ligation in our murine model of EAE, there's a definite sex preference, okay? And so I don't know that that translates across species, but we see a marked difference in sex when we do EAE in a mouse model. Other questions? We got one microphone, Gary, that's going around. Yes?
Yes, I am a male, and I do have MS. 33 years worth of it. As I'm listening to you, I'm an individual that went to China for stem cells, and I had an excellent experience for 23 months. I am willing to go out on a limb to get things done. This sounds like a fairly good and well-researched application for people who have MS. I'm quite interested in going to the next step. I know they do it probably in China. Well, I don't want to do that. I want to stay here. What is the next step to do?
Well, first off, Gary, you can take that, but I think I don't want to be too perturbing here, but one of the, I think, untoward consequences of what we've been doing, there's been a lot of medical tourism that's been going on, and I think, as we agree with you, that it would all be better if there were local, regional areas where patients could go so they get appropriate follow-up in their neighborhood, because that's one of the problems. I mean, getting it done, and we're not trying to in any way impugn the procedural, but it's just that follow-up is critical, and if you have something done in another part of the world, it's unlikely you're going to be commuting back and forth to that, and that creates problems, to be honest. So, Gary.
One of the things I just wanted to add, and I know we've kind of said the same thing a lot over the last hour, is you mentioned well-researched. And the problem is that it isn't. And I think it's really important because I think that one of the things that I've been seeing, we've treated hundreds of people, and to be fair, a lot of the patients come at it from a bit of a different perspective than a lot of the doctors that we're hearing about at meetings like this. And a lot of times from a patient's perspective, the level of research that may be needed to satisfy you as an individual may be less than what it takes to satisfy like a whole society of doctors to say that enough evidence has happened. And so I just want to address two things. The first is just the concept that I think there is a lot more research that needs to be done. So it really takes a unique individual, I think, to want to go through a procedure like this today, because there are so many questions that need to be answered that a year from now, it is inevitable that we're going to be doing something different than we're doing it today. I can guarantee you that. And so you may look back at your experience, that you had and say, oh man, I wish I waited a year, then they would have known X, Y, and Z. So you have to be comfortable with that there are things that we're going to find out. And because of that, I think that it makes all the sense in the world what Mike said, is that the medical tourism thing has its limitations, that flying across the country or flying around the world limits your ability to be in close communication with the physician who treated you, to understand what these advances are, and to talk with you directly and in person, looking right at you, to talk about how to best take advantage of the things that we learn over time. So I think that's the best advice I think that hopefully all of us can give to somebody looking to seek this particular treatment.
Very well said, Gary. Other questions?
I got a question. I can speak up.
Okay, go ahead, and then we'll go over here.
I've heard this 22% quite a bit of the general population have stenosis but don't have MS. Are you guys following that 22% to find out if in a year or 5 years they end up with MS?
Well, I mean, that's a random population. We know that 22% of the population is not going to end up having MS, so that's...
Well, I'm just wondering, I mean, Dr. Hake, or Mark, you looked at my MRI, I know you did. At some point, I must have been stenotic, but didn't have MS.
Well, I think your point is well taken. I will just say one thing that, and I'm a big booster of MR, and Mark knows that, and Mark's shown the protean number of benefits and value of MR. But there's a cost to that, okay? When we talk about doing MRs in non-MS patients, normals, someone's going to pay for that, and it's not going to be insurance. And so we have to have the funding built in place that we can do those types of studies that you want and that rightfully need to be performed.
I'm just saying, if you do the MRI, somebody spent the money, follow that person, see if in 5 years they're diagnosed with MS at some point.
Well, that's a fair point. Mark?
So I think actually you bring up a very important point. With something like 10,000 treatments out there already, there's almost no normals. And I think we need to be doing a lot more normals in these trials. We need to have done hundreds and hundreds of normals. In Bologna, I presented a study where we went back and retrospectively looked at using CTA. This was done mostly for people with carotid atherosclerosis. And we found only 7.6%, not 22%, of the people with CTA showed problems. So it's possible that the MR shows a slightly higher amount, or it's possible that that population was related to other MS patients. So somewhere, maybe it's a little lower number than 22%, but in this particular case, 250 is a pretty big number of random people, and it's about 8% in the normal population. So I think before we can really say anything here, to answer your question, we must do many more normals. And I'm not sure if you're doing normals at this point, Gary, but we have a study in Detroit that we can do 150 normals. So if you know people who are normals and not directly related to you, like your children, for example, we can start doing this type of study. And I think in Canada they're doing some normals as well. So this is very, very important to get people to participate in that aspect.
With the follow-up of those normals.
I think that needs to be built in, but that's not what's happening now, but we get your point on that, yeah. I mean, when we're doing normals at Stanford, and we pay for every one out of a research fund. There's no other way to do it, you know. Yes?
My question is around the concept of when you're doing the ballooning, the angioplasty, going past maybe the diameter of the vein and what I guess the term would be over balloon, and then with stents, if someone is re-stenosing, what risk or how much experience has been with putting
Sure,
stents in?
that's a great question. So we got two questions. Sal, why don't you take the oversize, and you can talk a little stents, but we'll let Bulent deal with the stent question too, okay?
We have to be sure of what we're dilating, and that's still very controversial. And there was a very enthusiastic advocation of very large balloons to dilate the veins. And it's not just the size of the balloon, it's the pressure of the balloon and the length of the balloon. All of those are important components. If you believe that there's some fibrosis of the wall of the vein, it's going to require a different technique and approach than if you believe that it's interior of the vein and the valve that's the problem. Because if the valve is the problem, balloon might not even be the right approach. It might be a valvulotome that can cut off the excessive abnormal part of the valve. So we really can't even answer that question. I can tell you that there appears, no science behind this, but anecdotally there appears to have been an increase in thrombosis with the popularization of the larger balloons. That doesn't mean necessarily that it was the larger balloon that caused that. It might be other factors like what type of anticoagulation was given, etc. So there is no good answer that's definitive for any of the questions. It really depends on your approach. Some of the approach is to use smaller balloons, accept perhaps less than an optimal improvement, but reduce the risk of thrombosis that might occur with a larger balloon. So I can only give you more question again because we don't have enough information, and it's the reason why I don't think it's appropriate to be doing randomized trials against the placebo unless it's multi-center and unless there's consensus about technique, which I don't think we have yet.
Okay, fair enough. Bulent, when, if ever, would you use a stent? Under what situation?
It is complicated a little bit, but I do go over this with the patient very specifically, every patient that I deal with, because it's really important. Once you use a stent, it's in your body, it's there, it's not going to come out. And the advantage is it will give you immediate better result than angioplasty. And it does, the stents do well in larger vessels, but again, the neck area is an area that's movable, and we know that stents can fracture, etc., that may aggravate the stenosis rate. So we have no data in the jugular of what the stents are going to do 10 years from now. I mean, maybe it's going to be fine 1 year, 2 year, 5 year, definitely better than angioplasty in the primary patency rate, probably. But in the long term, MS patients have a longer survival rate. We don't know what happens, and you may lose that vein completely, so you have to think about it twice. So I only offer it to the patients who are severely disabled, and then they're not responding to angioplasty, and they have a very severe stenosis or occlusion.
Gary, why don't you add that? Let's just put a hypothetical, and then you can do that and tell us a little more. Patient comes back, had a great symptom response, and you said you'd like to see a good response sustained for some period of time, let's say 5 months, 6 months. They come back now with return of symptoms, and you see a vein which is narrowed, which may be something different than what you were primarily treating, a response, and you alluded to that. You angioplasty them again, and they get a good result, and now they come back in 3 months. What's going through your mind? What would you do? And then you can sort of generalize about when you use stents.
Sure. Two things. I'm going to answer that question second. The one thing I wanted to stress with you, to add what he said, is that one of the, I think, common misconceptions that are out there is that angioplasty in and of itself has very little risk. And I think that Sal alluded to it, and I think the larger balloons, tend to carry some risk. I agree with that. And even just whatever we deem would be an appropriately sized balloon still carries some risk. And when you blow up a balloon inside a vein, there is a chance, maybe it's a small chance, but that the vein can react in a way that we're not expecting. And it can in turn really aggressively narrow down, clot can form, and then there could be a complete obstruction of the vein. So sometimes that situation is best addressed with a stent. So that may be a situation where, in a case of primary angioplasty, that's where we may turn to a stent in what we would consider to be a salvage situation. Meaning if we don't put the stent in, the vein will essentially be lost and functionless. So that might be the primary situation. In the situation where Mike mentioned, I think that's a conversation between me and a patient. Certainly if someone goes 5 months and does well, we repeat an angioplasty, then they go 3 months, we're going to have to sit together and be our own fortune tellers, for lack of a better word. Do we think that the third treatment is going to go a month? Do we think it's going to go 3 months? How aggressive does the patient want to be? I think these are conversations that are best left to an individual discussion between a doctor and their patient. But I think, again, what a patient can't be left with is the idea that the stent is necessarily better than an angioplasty. It's different than the angioplasty, and maybe it'll lead to a different result. But still, 3 months down the road, that stent itself, or the inside of that stent itself, can narrow and cause just as similar of a problem as a repeat angioplasty.
Yeah, I think we could also say that if indeed you have, we would call it I don't want to use a technical term, but when you come back sooner and sooner after the result, that probably the vein is reacting in a bad way to what's being done. That more than likely means they might react in a bad way to the stent. That something about your individual vein wall, your constituency of the tissue, is not happy being perturbed by any endovascular procedure. So the magic bullet of the stent is not really true. It's just, unfortunately, that frequent flyer approach is not going to magically just turn around with a stent.
Right. It's really important to know that.
Okay, questions. Now, I promised we were going to get out of here, so we're going to limit questions. We could be here all night, but I think we aren't going to be. So let's take a few more questions, 4 more questions. Okay, number 1.
Okay. Dr. Siskin had referred to this before, but the general question is for everyone. You had talked about possible inflammatory response subsequent to the treatment. So I wanted to see if any of you had any thoughts on that, as well as if any patients had come back whose symptoms had gotten worse after the treatment. We've talked about getting better or no response.
Okay, 2 questions. Let me frame number 1 for Don. Is there anything that we can influence or limit the inflammation from this procedure that you're aware of? It's coming down the line, that you can, drugs or other things? And then after you answer that, you can address if anyone's gotten worse in your experience, and then maybe we'll ask Lindsay to comment on that, okay?
Yes, thanks. Answering the second question first, we have seen patients get worse. It's under 1%, but that certainly does happen. As far as limiting the restenosis rate, whether that's inflammation or migration of cells into as Mike said, a perturbed area, we think that adding antiplatelet agents at the time may have an impact on that. But certainly there are a lot of new devices coming down the road, and this is the conversation we have about stenting at the time when we treat patients too, is that there are drug-eluting balloons, there's drug-eluting stents, potentially bioabsorbable stents, a lot of new technologies coming down the road, and they have a huge impact on how we treat this, and it may address those issues that Mike Dake was alluding to, is that maybe when you're getting a rapid recurrence, you're really dealing with a vessel that doesn't want to be perturbed anymore, and you have to intervene in some other way, and maybe that's in a pharmacologic way with a device that's going to deliver a medication to prevent that from happening.
Do you have experience with anyone getting acutely worse or immediately
No, more over time.
More over time.
We
Okay.
certainly see those people get better immediately, but thankfully we haven't seen anyone get worse, but we haven't seen one person continue to deteriorate.
Lindsay's a pioneer and is an expert in certain drug-eluting technologies. In your sort of wildest dreams, what do you see here for the team?
Well, drug-eluting stents mean that you put a drug on the stent, and then when the stent is implanted, the drug comes off the stent and goes into the wall of the blood vessel and stops that reaction from happening. So if you think of a sliver in your hand, you get a reaction to it. It's exactly what happens when you put a stent in. And everything that's been done has been developed for those stents in an artery. And an artery is very different than a vein. An artery, remember, is a very thick-walled blood vessel. A vein is a very floppy, thin-walled vessel. And so when we did our early studies, we also looked at veins, not specifically CCSVI, but just looked at drugs going in. And veins behave extremely differently to drugs released from stents than arteries do. So it would, it really is a very simplistic idea that you can just take that stent that's designed for an artery and stick it into a vein and hope that you can see the same benefit. So veins behave differently to stents put in that don't have drugs on them, and then they behave differently to stents that do have drugs on them. And so just like every other aspect of CCSVI, we really don't have enough information.
Yeah, and I think it's also fair for you to know that none of these stents that we're using were designed for veins. The type of stent that may be ideal is not yet defined for a vein and may in fact be different than what we use for arteries. Okay, how about right down here, sir?
Regarding the testing for
Yes.
CCSVI condition, you test using MRI, is that correct?
Well, MRI is one of the tests that can be used.
Okay.
Doppler ultrasound, duplex ultrasound.
There's a 64 slice CBT.
CT, yes.
Do you have an opinion as to what might be more effective? Which type of testing might be more effective?
Okay, very good question. And so basically you're looking for the thing that right now most accurately can diagnose CCSVI?
Yes.
And this snapshot in time, and this, just like the devices, is moving down the track, and I think that the jugulars are probably pretty easy to identify regarding if they're stenosed or not, but the azygos vein is tricky in any case, isn't it? Absolutely right. I think probably of all the technologies, people can weigh in, it doesn't matter, but I think CT for an azygos is probably anatomically the best way to get a rendering. But again, there are a couple things that we want to be sure you're clear on. There's anatomy, and then there's physiology. When we're used to arteries, anatomy is a pretty faithful rendition of what we can expect to be happening, but in veins, clearly, as you well know, anything from respiration to head rotation to muscular strain can cause changes that may be narrowing that is truly just a function of that dynamic exercise. So we want to look at physiology too. So right now, to be honest, we're not 100%, I think it's fair to say we don't have one test that is truly ideal. There are places, and again, remember what I said before, an MRV is not an MRV is not an MRV. Likewise, the Zamboni criteria and how they're evaluated are not yet reproducible in widespread terms across this country because it's a very subtle, nuanced study that needs a lot of experience and a lot of training. So at this snapshot in time, I think most of the evidence would point to Doppler ultrasound, but MRV, certainly theoretically, as Mark's shown you, has a lot of potential opportunities to be used as that study. Sal?
I think Mike hits it on the mark in the physiology. If you look at the whole system as basically a body of fluids with a number of inflows and outflows, we're not really looking with the ultrasound to detect a specific anatomical abnormality. We would never, for example, do any of these tests and then put a catheter into the vein and dilate whatever we imagined we were dealing with based on an MR or an ultrasound. The catheter venography is really the way we rely upon to analyze the stenoses. So
once you're actually in the vein.
yes, because none of the testing, none of it really adequately evaluates all of the, the jugular veins are pretty simple and they're not very well reproducible. But when you start looking at azygos, lumbar, vertebral vein, ascending lumbar, all the other vessels that contribute to this large body of fluid, you're left with a venogram as Gary calls it a tarnished gold standard, and I think you either have a gold standard or you don't, and that is what we have right now. I don't think it's going to be the be-all, the only thing that will work. There are a number of interesting technologies that will teach us more about what the interior of your blood vessels look like. But we really need to, you're looking for a key to open up a door for possible treatment. So either test will show you different things, but both of them lead you to have some confidence that you might have some abnormality on a venogram, which is a minimally invasive but an invasive procedure. Either test will do that. If you rely on either of those tests to make your treatment plan, you're going to be problematic. But if the door opens and you can say with some reasonable confidence that you're likely to have an abnormality on a venogram, and if you're willing to pursue that, then either test will be adequate, provided it's done in a proper, standard way that gives you the information you need.
Fair enough, Mark. And we're going to have 2 questions after Mark answers.
Just a very short comment here. To reiterate what you said, Mike, is the CT is a good anatomical way to do this. Most of the studies we review, they take about 10 seconds to acquire the data. In the MR scans, it also only takes about 10 seconds to acquire the 3D data. But the anatomy is not enough. You can have absolutely normal-looking vessels and no flow in them. So you have to get the physiological information or the quantified flow information, and that could be ultrasound or MR. And what Sal said is true. Then you're going to follow that up and you're going to do an angiogram. I would say there are a few cases where the angiography isn't perfect either. And so there are complementary situations where having the imaging with the angio is probably the best full concept to do.
I would just say, and maybe in another way, that each one of these tests right now has recognized strengths and weaknesses. There is on the MR with just anatomic renderings where we just can't tell about the valve, and we've already said that the valvular area is very key. Remember, an ultrasound, that's a very long, it's not 10 seconds, that's over an hour. Difficult to reproduce, other things, but the ultrasound has the ability to see real-time what's going on. The MR, to get that anatomic image, sums up a bunch of cardiac cycles, and you may be missing some of that dynamic. We don't have exactly what you want right now. Okay, question.
Yeah, I know that the Alliance is new, and there's a lot of things that we know that we don't know yet. My question, if my cognitive skills will stay in place here, is can we take bidirectional research, right? Meaning the old, what we already have seen, whether it's for this procedure or not, and take some of that information, and then moving forward, that information to put it together to close that timeline so that we can get more money. You know, the bigger organizations, they've done research over years and years and years, right? And that's how they get their money, because they have stuff on paper. Well, can we justify it by taking old information and the new information, squish it together and say, hey, we've got an idea to go out there to get more money? And then if that made sense, my medicine may not kick in. And just because I know we have just one more question, so I'm going to make a subcategory. Longevity. If I've had symptoms, because I have MS, and if I've had symptoms for quite a long time, after having this procedure, have you found that if someone has had it for a long time, they're less likely to have as good a response as if someone's only had it for 5 or 10 years?
Okay, let's take the last part of that question, or the sub-part first. Gary, do you, or anyone wants to answer?
I just think any answer we give you is going to be extremely anecdotal. I don't think anyone has studied this in a controlled enough situation to determine if there's a linear relationship between, let's say, age of the patient or the duration they've had the disease or the types of symptoms that they've had. Certainly, I think probably all of us can agree that patients who've had MS for years and have severe symptoms are probably a little less likely to see the type of response that they may be looking for. But everyone has a great story to tell. Patients that we didn't think would see a change, and they've seen a change. So it's hard to say. You can say, well, maybe there's a little bit of a less risk of someone like that responding, but on the other hand, why shouldn't it be you? So it's really hard to know at this point, and I think it would be really unfair to give any type of prognostic information based on anything right now, because nothing's been studied structurally enough to be able to answer that.
Yeah, I think that's fair. I certainly wouldn't. We don't know enough to really exclude any possibility right now. I think from Bologna, Sal, I think there were a couple studies that did say that the more progressed you were on an EDSS score scale, the more involved the veins were. I think we're starting to get a little more comfortable with that concept, but that has nothing about how you might respond. In terms of this idea, could we take old and new? It seems like, that to all of us who are kind of immersed in this, that we're moving very slowly, that we're sort of stuck in time, and some of this is Groundhog Day again. But in reality, things have happened very quickly in a fairly short period of time. And so I'm very confident, and I think many of us are, that this will move forward in the type of information that you want, that will inform, again, in this stepwise fashion, bigger trials, more robust trials, that will recruit the funds to do those trials will happen. It's sort of it takes strategy and tactics, but I think we'll get there. Okay, one last question. Anyone got it?
Mike, just have something to add.
Okay.
So I was going to ask you, have you done this on progressive patients and seen the results? Either primary progressive or secondary progressive?
I've got progressive MS, and I saw wonderful results.
Me too.
Was it primary progressive?
Primary progressive.
That's great.
Just diagnosed
Secondary.
last week.
I have secondary progressive and I've seen results.
Good.
I have secondary.
That's a good study, let's think.
Maybe we should just quit on that note. It's very positive, and was there one more question?
Well, I had one question, and it's maybe more personal to me than the group, so I didn't really want to ask it unless I felt like I could. But I've been told that I have hypoplasia in my left jugular, so it's 1/10 my left jugular than the right. What I don't understand with that, though, is how am I able to be treated? Am I a candidate? Should I just go with a venogram just to go look, but not expect the ballooning? Would a balloon damage my veins, like if it's too big? There's only 1 millimeter to my left jugular, my right is 10 millimeters.
Well, that's a very good question, and it's not just only relevant to you. People are made differently, and we see that exactly what you said.
Okay.
Now, this is based on an ultrasound, or what?
Yeah, at Georgetown, right before they cut off, they were about to schedule me to have a venoblast, but then they cut down and shut down the...
Okay, Sal, hypoplasia on an ultrasound. What do you do when you see that?
I must say that the first thing is I have to temper your enthusiasm, and that this is a much more challenging experience than a valvular abnormality, which is relatively simple. We do mature hypoplastic veins for other diseases. They're different circumstances, and they do improve. But I don't think we really we have a good technique. On the other hand, I would say that you don't have a vein. A hypoplastic 1 millimeter vein is really irrelevant. So
Like vermicelli and penne, right?
no, I think that what I think you need to do is see. I don't think there's very little downside to trying to slowly dilate the vein. And I'm not sure if it'll work, but.
Well, I was just wondering about the rupturing, or am I going to be doing damage just to go to look at it? That's what I'm just concerned about. It may or may not be.
I think that there's a good chance it will thrombose, which it practically is now. It may very well have been a thrombosis to begin with.
But Sal, there's no harm to her having a
That's right.
diagnostic venogram. I mean, you're not saying she's going to thrombose from a venogram.
Without the balloon, just to look at it.
Confirm the ultrasound.
I mean, we want to make sure it's 1 mil, you know, I think that's probably.
Can I just answer that? Just let me answer that.
Okay.
I would never do a venogram just to look. It would have to be, for me, it would have to be with the possible intention of treating, not just to take a look.
Thank you, because that's kind of where I was at. I'm on the fence just to look, and I just don't think it's worth the risk until maybe a few more years of study. And also, I've seen people do, I saw one in Italy, they did a, what do you call it, you cut it out and put a new one in? Transplant. And I don't even know if that's even doable, but I just wanted to know, that's why I'm here today, and thank you for having that for me.
Okay, there's one caveat to that though, and that is that what Professor Zamboni described is that, did they only examine you lying down or did you sit up as well?
I did the proper protocol. Georgetown University did it the right way, and yeah.
Because, you know, we see hypoplasia in veins, and obviously you sat up.
I didn't have any
that's
reflux.
what happened.
Of the 5, I didn't have any of them, except for the one reason why he said he could suggest I have a venogram just to go look and see why I have the hypoplasia. And maybe I have something in my azidus, because he wouldn't know if I had that.
Anyone have anything to add on this?
Thank you.
Thank you very much. Well, I think it's been a great evening. We'll let you get out of here so we don't have to spend too much time. Thank everyone, panel, audience, and especially CCSVI Alliance.